Okay, let's hear the rebuttal.
Okay, I just have 2 slides that I'm putting up while I'm doing this, then we'll talk about
So
some
is it a
talking
hard
points.
day's night, or is it a long and winding road, or?
You're about to find out. So, Steve, I see you learned absolutely nothing from my talk. You're still trying to treat asymptomatic TR, and honestly, it is time to let it go. So again, to treat an asymptomatic patient, we really have to set the bar very high, right? If you're treating minimal symptoms or asymptomatic symptoms, you're starting a clock until the next potential intervention. And so at the end of the day, we need to know that if we're going to be treating early in the disease process, that this intervention is going to be long-lasting, and then it's going to lead to improved long-term outcomes. At the end of the day, we have to practice evidence-based medicine. I think that there are a lot of slippery slopes, that occur in this space, and that's largely because of all of the unknowns that we have. Steve, you said, what's the definition of asymptomatic? Once a patient's on diuretics, isn't that a symptom of tricuspid regurgitation? And maybe it is, I don't know, or maybe it's a symptom of underlying congestive heart failure and underlying myopathies and whatever else is driving the functional TR. So I think really differentiating between our TR mechanism is going to be very important as we continue to sort out our interventions for tricuspid, our indications for tricuspid interventions down the line. But for functional TR, I think it really is very unclear. Slippery slopes, if you want to say we want to treat early, should we potentially be treating 2+ TR? That's before the right atrium, right ventricular changes have happened. So if we're starting to, try to prevent downstream problems, should we be intervening on the tricuspid valve, that early? Should we do it as soon as the patient has uncontrolled AFib and we know that the TR is going to happen? Should we intervene on the valve at that point? I think that there are just a lot of different questions here. The fact that the TriClip and Evoke are such low-risk devices, I think is absolutely amazing for us in the field, right? It really opens up the ability for us to think about doing some real trials. It's hard to do that when you have a high-risk intervention, but if you have a low-risk intervention that's overall, very safe, we can do this the right way. We can do the trials. We can understand what the true indications are. We can understand the right timing so that when our patient comes in to see us, we can, say that we really know that they're going to do better. I don't know if this happens to you guys, but, patients will come in to see me in clinic, and they have severe TR. And I'll talk to them, and they have this, mild symptoms. Let's just talk about mild symptoms, not asymptomatic. And the symptoms are, I don't know, I just feel kind of tired. I don't know, I don't have a lot of energy. And sometimes I say, well, I don't know, maybe if we fix the tricuspid valve, maybe some of those symptoms will get better. And half the time the response I get is, but I don't really feel all that bad to start with. And as soon as the patient says that to me, I don't feel all that bad to start with, I have to take a pause and a step back and say, wait a second, if you're actually feeling really good, can I really look you in the eye and say, if we do this intervention, next week, I am going to make you feel better, I am going to make you live longer, I am going to improve long-term outcomes. There's just a lot more in this space that we need to understand. So at this point in time, today, do I think we can be intervening early? No, I think we have to stick to what we know. We have to stick to what we've seen in the trials. And if we want to treat TR earlier, we need to do it the right way, and we need to practice evidence-based medicine. Down the line, are we going to be treating TR earlier? Honestly, I hope so. I hope we have data to show that we will have, meaningful methods of preventing patients from being in this state of severe TR, severe RA, RV, dilation, and dysfunction, because we know that once we're at that point, it is too late. But right now, today, if a patient comes in to see me, I don't have the evidence to say that if I treat the valve, I'm going to improve their outcomes. Okay, on to you, Steve.